Well, there's things called LTACs, so these long-term acute care facilities. In the middle there are basically kind of subacute ICUs. Most of the folks that go to those are like this individual have a tracheostomy and are on chronic ventilator use with potential for weaning, but sometimes it's more complex than that. In terms of within the hospital, there's acute rehab. Usually these are reserved for post-stroke patients, but if you have an older adult that has multiple comorbidities, high medical complexity, and can endure 3 hours a day of rehab, that individual, for example, post-acute heart failure, might qualify for acute inpatient rehabilitation. So it's important to really hone in on the medication regimen. So upon discharge, it's important to indicate what each medication is for, and what other stop dates. I can't tell you how many calls I get from the nursing home that got discharge orders from the hospital, but they didn't have stop dates, which, for antibiotics for one, but remember that if you prescribed a antipsychotic for delirium, you have to have a stop date for that, for either weaning or a stop date. And nursing homes will no longer, because of Medicare rules, will no longer accept PRN medications. Also, it's important to, again, if you have a tapering schedule, to make sure that the transfer note indicates that. Discharge planning is a good point for targeting medications for deprescription. Those include NSAIDs, certainly proton pump inhibitors, which over the long run cause reduction in bone quality and can predispose individuals to acquiring C. difficile colitis if they're on antibiotics. Laxatives, unless they're on chronic opioids. And then sleepers are the bane of long-term care, well, and community care too, because any of the Ambiens or the Lunestas, they're all associated with increased fall rates. So you want to clearly document the medications that are new, and the reason for that is that if there's any side effects, those are going to be the ones that are most suspect for creating medication side effect. And you want to avoid the medication symptom cascade. So if somebody got started or escalated on their antidepressant medication, an SSRI, and are complaining of loose bowels or diarrhea, and then all of a sudden they get put on loperamide or some anticholinergic, they become more confused or have behavioral changes, and so forth, that are just this constantly dog chasing its tail of one medication being used to treat the symptoms of another. It's so important to educate both patients and caregivers. When going to home, it's important to let the patient know what their follow-up appointments are, and also to alert them to any warning signs. You don't want to overstress out the patient and the family, but by the same token, you want to give them some parameters or guidelines for what to watch out for, as well as self-monitoring, right? So whether they're monitoring oxygen, clearly weights in heart failure situations, and so forth. And so these are well-placed instructional opportunities for what we call self-efficacy in chronic disease management. You also want to identify which referrals you've made, and certainly it's always been my policy, and I think research has shown pretty well, that the discharged patient should be seen from the community setting within 7 days of hospitalization. They usually say 7 to 10 days, but the sooner, the better, quite honestly. When the patient is discharged to another setting, such as skilled nursing facilities, they should know the nature of the new institution, what their strengths, perhaps what their weaknesses are, and what they can expect, as well as who will be following the patient. So if they don't have their primary, technically, in any nursing home setting, the primary care provider of record should follow the patient into the long-term care setting. But a lot of times, as we know, primary care providers don't have either the time or ability or interest. So only one out of 3 doctors actually have ever set foot in a nursing home in the primary care arena. So we know that the vast majority of physicians do not go to nursing homes. And so then that means that the older adult that's been transferred there will have a new doctor, a new face, a new provider, which may be a physician extender, a physician's assistant, or a nurse practitioner. And so it creates a whole new gap in understanding expectations that needs to be addressed. So it's important to communicate with the primary care provider. So some of the information that you want to convey are pending studies, some of the nuances of goals, that the patient was, for example, this patient was doing well until they had intermittent chest pain, and then they wound up getting treated for a incipient coronary artery disease that was discovered during hospitalization, but now they're emotionally crippled because they're afraid they're going to get a heart attack if they do any rehab. So, dealing with those psychological overlays may be an important nuance of care, rather than just saying, refer to a nursing home for physical therapy. So you might want to, for instance, if you're the nursing home provider, you might want to order psychologists to evaluate the patient for cognitive behavioral training or any other types of interventions that might help in that transition of what's equivalent to a post-traumatic stress syndrome. In terms of the promptness of the discharge summary, I would highly recommend that the discharge summary include the 4 M's. So if you can evaluate what matters to the patient, what are their goals, as well as talking about the medications, the reconciliation, and what was deprescribed. The other 4M is mentation. Are they still delirious? Have you done the confusion assessment method prior to discharge? Have they had a mental status check with the St. Louis University mental status check? Are they depressed? Was there a PHQ-2 screening, and so forth? And then what is the mobility goal, of the individual? So that's also important. So we also want to talk about methodology for improved transitions of care around quality improvement efforts. And so what I've represented here is the prototypical plan, do, study, act cycle. So these are called PDSA cycles of rapid change. And so we'll look here shortly as to what some of the ideas are for improvement in transitions of care. But basically, you want to look at the medical literature and say, this is a nurse visit program post-hospitalization. Is that better than what we're doing currently? Or can we create a post-discharge health coach? Should that health coach be within the patient-centered medical home, or should it be a standalone post-acute care coach? So these are some of the questions that you might want to dig into the medical literature and say, we want to apply this particular change in our system and see if it works. So then you actually do the change idea, you implement it, you test it over a period of just a few weeks, basically, a month to 6 weeks, and then you study it. You collect the data, and for example, if your primary goal is in transitions of care to reduce rehospitalization rate, that would be one of the forms of the data that you'd want to collect. And then you look at the data and you say, by doing a home visit program and including a health coach in our transition of care process, that we found a 1% decline in rehospitalization rate. So maybe it's working pretty good for us and is reasonable, so we're going to adopt this intervention. So that's how quality improvement works, and hopefully you're familiarized with that process. And so for examples that come from, for example, the Institute for Healthcare Improvement, is to look at specific goals. So let's say you just want to do a process improvement, and so that would be the percent of improvement in communication with primary care providers, which may be not only a written but a verbal communication. So that might be your metric. The other metric may be better medication reconciliation at the point of transfer. And so you can see, for example, whether a pharmacy consultant improved medication reconciliation. And then some other ideas here. I like this one here at the second from the bottom, is the percent documentation of older adults of their geriatric 4Ms. And again, that just harkens back to the Rush Medical Center study that showed that by doing this in the hospital setting, that you can reduce future length of stay by nearly 1 full day. So to summarize our transitions of care, we know that older adults transitioning across healthcare are at risk for suboptimal care and AEs, the adverse events. We also know that successful transitions can result in more effective care plans. They can reduce the adverse events, and they will also, importantly, increase functional recovery. So to optimize the transitions of care, we want to enhance care coordination, discharge planning, and case management. I would add to that that if you have a geriatrics program, incorporating the geriatric team into this process would really serve the healthcare system well. The other points for an optimal discharge is medication reconciliation. And then here are some 3 steps that could be used for transitions of care. Certainly, the first one is to set expectations for the provider teams, and both ends, the primary care and the hospitals. What are the expectations of communication? Is it only going to be written communication alone? Will it be written and verbal communication based upon some parameters? And those need to be, what I would say, established as a policy. You want to tailor the communication strategies to the type of transition. So, for example, if somebody's going to home care, it would be important for somebody from the hospital-based team to communicate with the home care nurse to explain what your expectations are, what the problems are. And that would be very different to somebody that's being discharged home with a direct referral to their primary care providers. And again, you might want to alert the primary care providers that, this person's got recovering from acute heart failure, and it would be great if your team could give them a call in 2 to 3 days to see if they're gaining any weight. And then finally, we want to improve care transitions by using quality improvement, and to do so by using both regional and national metrics. So, for example, the emergency room use, or the rehospitalization rate in 30 days, or rehospitalization rate in 90 days. These are all metrics that are obtainable. You can work with your quality improvement office to establish those metrics and then compare your patient panels to those metrics. And again, start small. If you want to start with one small primary care practice, and then maybe start including 3 or 4 primary care practices, and you build your data set to see if what you're doing through your quality improvement is really having an impact. So that's the conclusion of this presentations on transitions of care. Again, just to emphasize that the inclusion of geriatric teams is extremely valuable and probably the most impactful strategy for enhancing transitions from acute care to the other settings. Thank you for your attention.